Okay, it's great to be back. This is our second year running. We attended Let's Talk Sepsis. I recognize some of you in the audience. And we're here to sort of brief you on what we've accomplished as a company in our this battle that we're waging in sepsis management, and also some of the progress that we've done actually in the UK. We're thrilled to report, and Chris will talk a bit more about the commercial aspects about PSP, pancreatic stone protein, which is our biomarker that we're now commercializing in the UK, and the effect that this has in the UK market and how we're deploying it across different sites. And this was all the result of last year's Let's Talk Sepsis. So we're thrilled to be back, and hopefully we'll have plenty of time for questions either before or during lunch. This works. Quick numbers, you know them all. I think there's no need to spend a lot of time on this. It's a big number. Some people may disagree with the size of the number. We may not always recognize how much we actually spend in the UK, but we always tend to use a lot of US numbers because they're so good at collecting numbers. And effectively, if you think the societal cost of 62 billion is not a big issue, then I think all of us need to reconsider the importance of sepsis. But it's 11 billion in the UK alone, and these numbers gel well with the rest of Europe, by the way, continental Europe. But we just focused on the UK for today. So 1 in 3 hospital deaths involves sepsis. You may question these statistics again. They're based on some US data, but I think it's fair to say some of you face this as frontline workers. Whether or not this is true, I think the overall statistic is quite accurate. And what lacks today, in our perspective from a commercial aspect, is there are no point-of-care diagnostic tools for early and rapid detection of sepsis. And this is where Abionic's PSP comes in, right? So Abionic, the pancreatic stone protein that we've developed over the past couple of years has this interesting capacity that it rises earlier than other markers in the bloodstream as a result of sepsis. What is PSP, pancreatic stone protein? It's effectively secreted by the pancreas, and it reacts to infection in the body. I didn't do anything here. Interesting enough. Happy to discuss, how the PSP actually works. We can probably take this offline. This is not meant to be a scientific conversation. But the fact of the matter is, all of the papers that we've published, all the research does show that PSP rises earlier than other markers in the bloodstream. Hence, its positioning as an early triage product or possibly as a monitoring tool in the ICU. What's the technology that we use? It's a first-in-class nanofluidic platform. Nanofluidic, microfluidics, to some of you this may not make a big difference, but the innovation here that came out of the EPFL about 15 years ago, this is how long it took us to develop this product, comes from the fact that the nanofluidics enables much faster incubation periods. So on a 7-minute test, there's a 2-minute incubation time and a 5-minute turnaround time to result. From sample to result, I would say all in is about 10 minutes if you take into account the worker's time, taking the kit, putting the gloves on, et cetera, but actual machine time is about 7 minutes. And that's a feat in of itself because this is what gives us that rapid result at the point of care, at the point of need, at triage, which is why we're now making a big push to make sure that this product ends up in the hands of frontline workers so that they can diagnose sepsis as early as possible. I'm now going to pass on to Chris.
Thank you, Patrick. Appreciate everybody's time. So obviously, Patrick's given an overview of the company and what PSP does as a biomarker. What I want to do is really transition to an overview of the clinical utility of PSP. So in my opinion and experience in the commercial sector, a diagnostic assay is only of use if it provides some clinical impact to patient management or therapy pathways. And also clear guidance from the company on how to actually use that diagnostic tool, obviously supported by peer-reviewed data. So PSP actually shows multiple applications across different patient groups and clinical areas. So many so as a company, we're actually trying to really refine that and narrow that focus down to specific areas. And actually how PSP is used in these clinical areas will vary slightly. So potentially using it in the emergency department as a single measurement, and then potentially in the ITU as sequential measurements, and then actually looking at the trends. So obviously there's a wide range of clinical parameters and laboratory tests available to clinicians together with a clinical presentation of the patient in the management of critically ill individual patients. But obviously there's a logistical issue associated with that with core lab technologies. You know, you need to take the sample, you need to send it to the lab. That lab's, you know, the sample needs to be processed and then reported and approved back to that clinician. So there's obviously a delay of, you know, between 1 to 4 hours depending on the clinical area that you're working on. This is where we feel that the Abioscope and the Abionic system and PSP as a biomarker could provide some real clinical utility. It's a rapid test, it's 7 minutes, as Patrick said. It comes from either capillary or venous samples. It's a very low technical ability to actually use the diagnostic, and yeah, very low skill required to actually process a sample. So, as I said, PSP has a number of different applications across different clinical settings. I'm going to focus on 3 areas today, so the intensive care, the emergency department, and burns units. So one of the core challenges is, you know, is my patient septic? Do they have a severe infection? And one of the issues being overlapping symptoms. You know, is the patient deteriorating because of their underlying trauma or because of a potential infection, leading to that diagnostic uncertainty. Now, we know that there are existing biomarkers available like PCT and CRP. PCT, you know, the latest evidence produced by Professor Paul Dark's group showing you can use that to for antibiotic stewardship, and CRP is a useful inflammation marker but limited specificity. So this is where we feel that actually there is a gap in the market, as Patrick mentioned, for a near patient rapid diagnostic for septic patients. So one application that we've actually seen strong interest and generated considerable evidence is in burns. And our understanding from a layman's perspective is it's quite difficult in burns patients to differentiate between inflammation and infection because of the underlying trauma. So this was a study that was undertaken in Zurich. So it was 90 patients and 90 patients, burns of 15% over their total body surface area, taking daily PSP measurements. The main outputs were that PSP was able to differentiate between non-infection, sepsis, and septic shock, but more importantly, actually showed an increase in the 72 hours leading up to that septic event, so that early indicator of severe infection. But also is equally important that the PSP levels remained stable for non-systemic infection, so it was able to differentiate. So another application that we've seen considerable interest in, and we're starting to generate more and more evidence, is in the emergency department at Triage. So obviously, you know, this showing the patient flow of people coming through the ED, presenting, and then being triaged for admission, waiting room, or discharge. So we don't see the PSP biomarker being used on those severely ill patients. You know, they're quite clearly very unwell and will get the appropriate level of care. On the other end of the spectrum, you have those patients that are of a lower risk, again, probably don't need this biomarker. But what about those patients that are in that grey zone, where you're not entirely sure and leaves that sort of uncertainty? And we have got evidence to show that if you combine the PSP assay with risk assessment scores like QSOFA or NEWS2, you can actually identify more severely ill patients. And again, just because the structure of the Abioscope and the PSP biomarker, it's rapid, it detects sepsis, easy to use, again, fitting nicely into the emergency department workflow. Okay, so now we have a presentation from Professor John Parissis, who's going to talk a little bit about his experiences of using PSP in the emergency department.
Dear colleagues, first of all, I would like to thank the organizing committee for this kind invitation, and also Abionic for the opportunity to discuss this important topic in the management of infection in the emergency department, uh, and also to highlight the role of pancreatic stone protein in this process. You can see here my disclosures. I will start from the structure of my ID. It's the biggest ID in Greece, covering 2,500,000 people, and also having about 1,200 patients per day at the emergency department, containing 2 triage rooms, 1 fast-track room, 2 resuscitation rooms. The main ED has 35 beds, and also there is an observational unit with 20 beds for the observation of patients that will discharge or admitted after 24 hours from a visit to emergency department. You can see here also the distribution of patients according to the triage level acuity process using in Greece for the evaluation of patients coming to the emergency department. You can see here that the vast majority of patients, over 60%, are in level 3 and 4 with less severe or mild symptoms. On the other hand, the minority is the severely ill patients, and finally there is a level of about 30% with very mild symptoms, who are patients who discharge from the emergency department. I believe that except the severely ill cases and the patients with very mild symptoms, there is a problem for the evaluation of these patients, level 3 and 4, and we need tools to reclassify these patients immediately after the first contact. And in this direction, I think that the point-of-care systems are very useful and valuable for the evaluation of patients in the emergency department. We have also a lot of them using in real clinical practice, starting from the ChemStat, evaluating the basic metabolic panel with electrolytes, BUN, creatinine, and lactate levels, the PathFast system with high-sense troponin I and evaluation of D-dimers, the Comba system evaluating the blood gas analysis, also NT-proBNP levels for differentiation of dyspnea in the emergency department. We use for research reasons a point-of-care system for the evaluation of PEN-KID, biodromedulin also, new biomarkers of hypoperfusion and renal dysfunction in the emergency department, the Febrix DX system for differentiation between viral and bacterial infection, and finally, the last years we use the Abionic system with point-of-care PSP evaluation for the risk stratification, and in order to treat it properly patients with infection disease and or sepsis, and also now we have a protocol about evaluation of acute heart failure patients at cardiogenic shock for research reasons. Actually, in 2026 Surviving Sepsis campaign, there is also a notice about the PSP use for the early detection of sepsis, and also as a marker for early risk stratification in patients with sepsis. We have from trials in the intensive care unit in patients with possible sepsis that the PSP levels are important biomarker with high negative predictive value, and also marker to differentiate between sepsis from non-infectious systemic inflammatory response syndrome. You can see here also that this is very high accuracy to predict early the sepsis in intensive care unit, and also to guide the treatment with antibiotic administration in these patients. In this direction, there are some trials using earlier the point-of-care PSP in the ED in order to diagnose early the sepsis in emergency department, to start immediately the relevant therapeutic interventions in the emergency department, and also to do an accurate early risk stratification in emergency department patients with infectious diseases. Finally, I believe in a emergency department overcrowded. There is a role also for PSP for early rule out in patients with low risk and also a concomitant infection. In this direction, there are few trials for the evaluation of PSP in the emergency department. This is also the first pilot trial, 28 patients with clinical suspicion of sepsis in the ED, at least two criteria for systemic inflammatory response syndrome at a possible site of infection. This trial highlighted the prognostic role of PSP after first contact of patients in the emergency department with higher accuracy than other classical markers like total blood count levels, CRP, or procalcitonin. The next trial is a trial validating the role of PSP in sepsis detection and outcome prediction in community-acquired infection, focusing mainly in intra-abdominal infections. 100 patients at PSP levels measured within 1 hour of admission. There was, as an endpoint, the composite outcome of sepsis, readmission, antibiotic treatment, escalation, and need for invasive treatment. And also there is high predictive value of PSP with area under the curve 0.892 in order to do a very early and safe rule out in these patients with infections, and also detecting the high-risk patients for sepsis, predicting the events the following days. That in this case, PSP seems to be superior than other biomarker in sepsis prediction. These results confirmed from the next trial, 156 sepsis cases, comparing with 206 no sepsis patients, and also plasma collected in the first hour on admission in the emergency department, and there was also a combined evaluation of value of PSP with clinical scores like QSOFA or NewScore. You can see here that the role of PSP was very useful because it reclassifies patients with low QSOFA as high-risk patients if there is a level over 300 nanogram per millimeter. In this direction, PSP levels over 300 nanogram per millimeters plus QSOFA score lower than 1 was similar to QSOFA score higher than 2 in evaluation of these patients. Finally, there was also additive value of PSP in the NEWS2 score, identify more patients with risk for sepsis in this population admitted to emergency department. Continuing the research in emergency department, you can see here a trial conducted by my team in Attikon University Hospital ED, focusing mainly on point-of-care PSP evaluation in consecutive patients presenting to the ED with suspected infection, with endpoint the prediction of adverse events by PSP, like death, development of septic shock, or need for evaluation due to persistent symptoms or worsening in 10-day follow-up period. We evaluated 102 patients. You can see here the difference between patients with events versus patients with no events during the follow-up period. The patients with events had higher levels of PSP, higher levels of creatinine, lactate, and procalcitonin, while there was no statistical difference between the levels of patients with events versus no events regarding the total white blood cell count or CRP levels. You can see here also the clinical characteristics, the site of infection, and the clinical confirmation of clinical diagnosis, and the triage levels in this population of patients. The vast majority of patients, you can see here, was patients with no severe symptoms, like triage levels 2, 1, and some of them 3. This is also an opportunity to reclassify these patients with new tools like PSP. According to the results, PSP was significantly correlated with procalcitonin, blood cell count, lactate. There was no correlation with CRP. And finally, there is also a correlation with clinical scores. Patients with adverse events had higher levels of PSP, news to score, Q-SOFA score, while no difference regarding to white blood cells and also CRP was found regarding to clinical scores. Thus, in my conclusion in this trial was that PSP measurement AD may serve as an early predictor of adverse events in patients presenting with suspected infection. I will describe now some clinical cases from real clinical practice, patients from RED. The first case is a female, 34 years old, with fever and flank pain the last 24 hours, with past medical history negative, with no medications, clinical findings, sick appearance, blood pressure 95, heart rate 97, a good oxygen saturation, with fever, while on physical examination without significant clinical findings. In point of care test, we found in urine stick positive test for urinary infection. The lactate was normal, but PSP very high, over 600 nanogram per millimeter. Later, we found that also there was a high level of white blood cells at CRP levels, but patients admitted according to the clinical findings and also PSP levels very quickly to the internal medicine ward, started IV antibiotics, and also later we found that there was also urine culture, positive urine culture for E. coli, and also positive blood culture in these patients. In this case, the PSP confirmed early sepsis detection and also early initiation of treatment. On the other hand, there is a clinical case of a patient 37 years old, a male patient without past history, with fever the last 2 weeks, with no recent travel, with negative physical examination, negative chest X-ray, and also the lactate was normal, the Febrix DX suggesting viral infection. The PSP levels was very low, 26 nanogram per millimeter. On the other hand, there is a relative high CRP, but according to the clinical findings at PSP levels, confirm the low severity of illness, and we have an early rule out with follow-up of the patient the next days, and the diagnosis was viral upper respiratory infection. For research reasons, the last time we use also the PSP levels for the evaluation of patients with acute heart failure. A significant precipitant factor of acute heart failure decompensation is infection, but also there is a high percentage, near to 10 to 20%, with no reasons of decompensation. And many trials suggest that there is also unmasked. There is also masked infection or suspicion for infection in these cases, and also PSP can help us to unmask the infection in acute heart failure, cardiogenic shock, and also we use this marker for risk stratification. We know also that some patients with cardiogenic shock has also a viral or bacterial infection, and there are some cases with mixed shock. And mixed shock has bad prognosis in these patients, increasing the mortality and also the need for invasive interventions. In this case, we have two clinical profiles. One clinical profile is the first clinical case, a female 60 years old with dyspnea the last 3 days, with acute heart failure, also with a critically case, transferred from a regional hospital to our department with possible infection as precipitant of shock. There is negative coronary arteriography, low systolic blood pressure. There is also signs of hypoperfusion with high lactate levels, high creatinine levels, high NT-proBNP. In this case, the PSP was very high, 479 nanogram per milliliter. Patients admitted to CCU, classified as mixed shock, started treatment with fluids plus vasopressors, inotropes, and also early antibiotic treatment and later ECMO. After 1 day, there was also positive blood culture for infection.
Okay, so just to provide a bit of an overview of where we are with the UK commercial activity. So we launched Abionic in the UK about 12 months ago, initially focusing on burns units, but now spreading out to the emergency department, ITU. We're seeing a lot of interest in liver units across the UK and paediatrics. We've deployed systems to the Queen Elizabeth Hospital in Birmingham in their burns and liver units. We're also starting an emergency department trial in Kettering and Northampton next week. Multiple other systems about to be deployed to burns units and liver units, and we're also looking at a large multi-centre interventional trial in the emergency department due to start hopefully this year, if not start of next year. So thank you very much for your attention. If there's interest to learn more, we're out in the exhibition hall, so please come and find us.